Ladies and gentlemen, up next is mental health, building a community of support. It will be featuring Mr. Mark Johnson, Sheree Mani, Mr. Rick Shrum, and Mr. Fabio Vander Mervy.
Good afternoon, everyone. Thank you for joining us today. Before we start, just wanted to say thank you to the Health Connect South team for organizing today's event. Russ Lapari, who's been at this for 9 years and pulling it off this year despite all the challenges in organizing these live events. So thanks to Russ and the team, and thank you all for joining us this afternoon. Today we're going to discuss behavioral health. It's a topic that's hit the news, hit many of our personal lives in ways we've never thought possible, but this has been an issue that's been facing the healthcare system, individuals, and communities in different ways over the past hundreds of years, and it's been manifesting itself differently, particularly because of COVID. Not a day goes by where we don't look at the news where there's some new headline and guidance from clinicians, some event that could have been prevented with better mental health services out there. And we're lucky today to have 3 folks who were really operators. They live in the environment day in, day out. They understand the challenges uniquely, and they understand many of the solutions that we need to think about at a community level and a national level. So with that, I'm going to allow them to introduce themselves. I'll start on the far right with Fabio.
Hi, my name is Fabio Vandemerva. I'm the CEO of DeKalb Community Service Board. We're a community mental health provider here in Atlanta in DeKalb County.
My name is Rick Shrum. I work for WakeMed Health and Hospitals. It's a health system based in Raleigh, North Carolina. But in a previous life, I was the chief operating officer for the second largest behavioral health management and consulting company in the United States.
My name is Mark Johnson, a board-certified psychiatrist, and I'm also a CEO of a community service board here in Georgia, Gateway, which covers the Savannah coast. Came to that position 7 years ago after 17 years in St. Louis with BJC Healthcare and on the faculty of Washington University there. So thank you for coming today. You know this is a key topic for everybody.
And again, my name is Sheree Mani. I'm a director with the Chartist Group. We're an advisory firm focused on healthcare services in the payer universe. I focus on investor-owned platforms who've had a lot of interest all of a sudden in behavioral health in multiple dimensions, and we'll get into that in a little bit. Well, I'm going to throw out the first question here to my panelists here. It's just, we have a series of mental health issues, and I want to better understand how they manifest themselves in your community and what you sort of see day in, day out. But thinking back to one of the key themes here is around connections and collaborators. How have you connected with other parts of your community and collaborated with others in your community, institutions or individuals, to address those pressing needs? So I'll start on the far right with Fabio.
So I think the past 3 years have been very different to the years prior to that, obviously because of the COVID pandemic. And I think what we're seeing is a result of kind of a collective trauma in the community. Specifically for our agency, we serve individuals that have no insurance or Medicaid clients, and that trauma has exacerbated a lot of the mental health issues that we're seeing. And I think during the pandemic and even now, where we're seeing from a collaborative effort is reaching out to community organizations, whether that be your local YMCAs, your churches, other nonprofit organizations who are initially getting the brunt of clients coming to them with more serious mental health needs, and then finding ways where we can support them, work with those community providers and bring those clients back into services, as well as working with hospital systems who are also seeing a significant increase in crisis services. Individuals coming to the ERs who are needing more inpatient stays. So how do we work with those hospital settings to provide support as those individuals transition and find ways that we can give alternatives to a hospital setting. So those are kind of the 2 big areas that we're seeing in terms of collaboration, is more of community organizations within our area and working with more hospital systems to address what they're seeing from a crisis perspective.
Just first of all, as somebody that's been around this field for a long time, it's exciting to see this many people in the room talking about this subject or wanting to hear about this subject. We've come a long way. we got a long way to go. We've come a long way. Just to give you an idea from our eyes, yeah, I thought that maybe that thing wasn't working. I was staying directional too. He said you got to talk straight ahead. I was trying to play by the rules, which is unusual for me. But what I said earlier was it's really enheartening to me as a person that's been around this particular space for a long time to see this many people interested in this subject matter. We'll talk more about this going forward, but it takes a village to take on this disease, and we need all of you. To give you a sense of what it's been like, we were overwhelmed in the behavioral health space before the pandemic, way overwhelmed. Now, it is really a third wave pandemic in my eyes. And what's showing up and we're experiencing in the hospital system and hospital systems across America is unsustainable. So it's time to make some change, and big change, sweeping change. Just to give you an idea, we have 7 emergency departments at WakeMed. One of them's a children's emergency room because we have a children's hospital. But we've seen a 30 to 40% increase on top of 40,000 visits a year that are behavioral health patients. 40,000. It's bigger in my hometown. Now it's 60. We've seen, the saddest part about it is the severity of the illness that we're seeing. And these guys live it closer than I do. But we've seen a 30% increase in suicidality, 68% increase in overdose. And the kids are suffering. A 66% increase in adolescent visits. So, and I try to put it in some context. So our health system is a level 1 trauma center, our big medical center. We also have a level 2 trauma center. So we see the sickest of the sick on the medical side of the equation. And I looked at some data, I had our person pull me some data and compare behavioral health visits to stroke, behavioral health visits to heart attacks. And strokes, we're seeing 4 times the amount of behavioral health patients than stroke patients, and 6 times the amount of heart attacks to behavioral health patients. So it's a serious situation, and it's going to take all of us to kind of work through this. So I'm really excited you're here, and hopefully we can enlighten you today.
When we get to talk, I'm sure we're going to get a parity question down the road. I'll come back to strokes and heart attacks. Coming to South Georgia, where there's a dearth of psychiatrists and virtually no psychiatrists, having been in St. Louis where we train 10 psychiatrist residents a year in downtown St. Louis in community health care, when we could transfer patients all the time to St. Louis University and their 10 residents in their outpatient clinic. The number one need I saw was workforce development. And so the collaborations in Savannah and in South Georgia have been considerable. One of the groundwork, building support for, frankly, spending money in mental health when you may have to surrender it yourself is very much like when you go to try to do something in a school. And some schools, the superintendent may want it, but you know you got to have the principals buy in. Some issues, the principals buy-in is not enough. You've got to have the teachers buy in. What happened in Chatham County 6 years ago, the county manager, in conjunction with the county commission, their oversight, began an annual Chatham County Mental Health Symposium. That was driven by district attorneys, judges, sheriffs, both community hospitals, the FQHCs, and we've now had 6 of those annual symposia. I've expanded it to non-professionals by adding a car show this year and last year. And the mornings are spent with kind of the educational materials But the afternoons really are work groups focused on what do we want to do in mental health this next year. So for the other collaborations, that really set a context. Stepping back from that, Chatham County for 8 to 10 years now has had a county blueprint. And the county blueprint really aligns all the stakeholders in the county. I may get to say more about that in a minute, so we all know we're moving the same direction. So when it came time to try to start a psychiatry training program, that involved, we had the support of both FQHCs, the support of the county commissioners, the support of the judges, the sheriffs, both of the community hospitals, Georgia's Department of Behavioral Health and Developmental Disorders, the support of the local state psychiatric hospital, and then affiliation with Mercer University and support of Dean Sumner. So in June of 2019, we were training no psychiatrists in South Georgia, and they were all aging out. People would retire to St. Simon's, but they weren't practicing, they were retiring. So today we now have 29 physicians training to be psychiatrists in Savannah and in South Georgia. We will start, that opens the door to other collaborations. So that's obviously a multi-axial collaboration for something like that to happen. Next summer we start training child psychiatrists. We have an agreement with Mercer to train marriage and family therapists with the master's program, place one of the divisions of Mercer program in Savannah. COVID got in our way, we were ready to go, and then began to run into workforce issues. We have a postdoc fellowship for PsyDs and PhDs in psychology. All of those things possible because of that real group of people that collaborated. And people that I've not mentioned that I was introduced to and became part of the process were our local state senators, our local representatives, the chair of the House Appropriations Committee here in Georgia. So very much an effort where everybody was on board, including our local federal congressman. Other collaborations. Savannah has been one of the places leading the state with what the Savannah Police Department is doing with its behavioral health units. Beginning about 5 years ago, the city, the police department, Gateway, all began some of the national county consultations, national council of cities consultations, which then moved to national counties, and began operating inside the police department a behavioral health unit that the officers can be called to and have a ride-along mental health professional with them in the car. And Gateway is the provider of that mental health professional. That's grant funded by the Department of Justice. And of course, as you all know, with the 1013 law here in Georgia, that's now a structure that's possible statewide based on what the local need is and the local collaborations. I can talk about collaborations for a while, but better get another question.
Thank you all. And each of you talked about really interesting initiatives that have been transforming your local communities, but behind all this, you need money. And that's been one of the biggest challenges. If you look at sort of behavioral health over the past 30 or 40 years, almost every major city had a behavioral health hospital with an outpatient service that sat behind it. Many cities have closed those down. I can't even think of any that actually still exist today in a major MSA. In 2021 alone, if you look at investors, private money, $5 billion was committed towards behavioral health. Many of those are like apps that sit on our phone. Many of them are new business models out there to touch patients. But to Rick's point, this requires a village, and they're not playing in the village. They're kind of playing on the periphery of the village. I'd like to hear how you guys are funding these needs and where you're getting the community support from the state or locally. And maybe, Rick, we could start with you because you have a really large initiative going on in Wake County that I think would be very interesting for folks to hear.
Thanks, Ree. Yeah, we put together it's called the Wake Med Behavioral Health Network, and it's really again, it takes a village. It's 37 different organizations that have come together for the goodness of the health and the well-being of our folks that live there. So it really mushroomed into something that, frankly, I had a vision for some of it, but it's gone much further. And I'd like to think of it as a novel model that every community could use or could use a piece of. We don't have all the answers, but I think we have some things that are useful to a lot. So we pulled together these 37 disparate organizations across our marketplace into 3 different networks, sub-networks. One's an inpatient network. We have 10 members. The furthest hospital is about 100 miles, but we have about 1,000 behavioral health beds inside that network and all the staff. We have an outpatient network that has started with 10, now we're up to 17 members. And we have over 2,500 clinicians underneath that traditional outpatient rubric. And we span, well, and the third network is our social determinants of need, community-based organization network, so real heart-based nonprofits, people stepping into the needs of the homeless, the hungry, the unsafe, and looking at we look at all this with, transparent glasses. So we pulled together these 37 disparate organizations with one goal in mind, and it's to increase quality of care and close gaps. And we did this back in 2017, so it's been operating for a while. We've also developed our own homegrown referral and communication platform. So everybody's connected from a technology perspective, which is just super because we can communicate bidirectionally. We also have advanced access, which I'll talk about here in a minute for our patients. And our partners can communicate together without WakeMed involved. So it gives us a chance to manage patients and on all their needs, not just some of them. So we put together these 3 sub-networks. We designed it based on the data that we received from our emergency room visits to say, what is it our patients need? How can we serve 80% of that population? And that's how we built our network, based on the clinical expertise of our partners. And so we distribute those referrals out to our partners based on an algorithmic approach where we use matching logic to match the patient's clinical need to our partner's expertise, close to their home, and that they take their insurance or lack thereof. It's really simple. Additionally, we put a lot of resources at our front door. We've got 45 FTEs, licensed social workers primarily, that do assessments. Behind them are PhDs to help with the hardest of cases. And behind them are our psychiatry team to help with the even toughest. And our emergency room staff that see 40 to 60,000 people a year. So they're not, JV in this game. So my contention is we know we have the best workup for patients in North Carolina. And any of you that have this experience in the behavioral health space know that our patients are some of the most complex. So literally, this game's simple. You figure out what's going on for real, and you match them to the care they need. And that's the magic of the network. We've seen results that, I hate to say the statistics because they're almost unbelievable, but they're true. We've seen a 90% decrease in the referrals that we send to our state hospitals in North Carolina now. And we've seen a 72% decrease in avoidable bed days, or I coin that differently. I call it days in waiting. So days that people are with us in the hospital setting, the medical surgical hospital setting, not behavioral health, not a good match, where they're waiting to be placed to service. And we've seen a 72% decrease in that time. So we're getting into that care that much faster. Access metrics are unbelievable. So what we've built is a model for today and a model for tomorrow. In the value-based world, we've really built a clinically integrated network for behavioral health. All this, again, takes a village. It was largely funded by WakeMed. I have the best boss on the planet, our CEO, and our board of directors behind this effort 100%. So they funded most of it. Our county helped, our state helped, each in different ways. Our city helped, and all of our partners that we put together helped. So it takes a village to get your arms around this. Now, all that to say this, we did all this work. We've made all this wonderful impact. We just filed a CON, Certificate of Need, in North Carolina, still alive and well, to build a 150-bed behavioral health hospital in Raleigh. Because with all of that, it's still not enough. And I don't think we're any different than any other community, but that's how we put it together. It's new, it's different, it's novel, and it's the beginnings of something really, really special.
Thanks, Rick, and congratulations on accomplishment of that.
Thanks.
Not a small undertaking. You know, maybe I'll let Fabio and Mark take that same question, but a little differently. Is, you know, it's not just dollars, but what innovative things are coming out of your different groups, sort of this post-pandemic environment?
Well, I think one advantage, but with the ARPA funding from the federal government, I think that allowed a lot of our behavioral health community providers to try new things with that additional funding. So for us, receiving some ARPA funds, we realized that, you know, during the pandemic, and a lot of our clients, they really couldn't get to our clinic, and not only could they not get to our clinic, but they didn't have the technology for telehealth. So we took some of the ARPA funds and created a mobile mental health clinic. We converted 3 of our transportation vans to actually have an office in the back of it with a telehealth system, and we staffed it with case managers. And with that, we could actually go out to the community and offer that service through that mobile mental health clinic. And I think what that has done is really extend our reach into the community. So when we work with schools, you know, some schools may say, well, we don't have space in the building for you. And say, well, do you have a parking spot? Because everyone has a parking spot. And so we'll go in, set up in front of the school with a parking spot, and then be able to see clients, see the kids, their parents, and do it where it's more convenient for them. So that, I think, has been a really good extension of our service delivery. We use some of the county funds that we got through ARPA for the police co-respondent program, so a similar program with Savannah Police. This is with DeKalb County. That is having that trained professional riding with a police officer. So originally we had one team, and DeKalb County is close to 1 million, population of about 1 million individuals. You know, one team for that area, it's not a lot, but we're able to increase that. So now we're looking at expanding that to 4 additional clinical staff to work with DeKalb County PD as part of that co-responder program. So I think those were ways where we could take some of that ARPA funding, look at unique programs that you can't really fund through traditional methods. Now, the problem with the ARPA funding, it is limited. You know, that's going to go away. And so I think the next step is working with the state agencies to say, and county agencies to say, well, here's the benefit of these programs. How can we continue funding with these programs? I think the other thing that we're seeing on the federal level is a real big push for certified community behavioral health centers, or CCBHCs. This is they're analogous to FQHCs, but mostly focused on behavioral health. So we're seeing a lot of funding through SAMHSA, through that individual providers in states can apply for, or states themselves can apply for, to create CCBHCs programs within the state. So that, I feel, is another good alternative and a good thing that we're seeing from the federal government, to have this more federally designated behavioral health center and funding for it. So I know we're hopefully in a matter of days, I'll find out if we're going to be a CCBHC or not. But I think that's a good source of funding.
No, thank you, Fabio. Fabio and I are both waiting to hear if SAMHSA funds us this month, actually. So I'm going to move to early intervention and prevention, because I think you've heard clearly there is a way to get an integrated behavioral health network. Use your data, flex, use your data, flex some more. There are specialty programs that need to occur, and flexibility. So all that's part of what the village does. Upstream from that, of course, is early intervention and prevention, and low budget approaches, which are typical for early intervention and prevention. In Chatham County, there is a Chatham County Safety Net Planning Council, which consists of the two community hospitals. The standing board members are the two community hospitals, the two FQHCs, Gateway, and then the whole council has another 80 members of it from all over the community. One of its efforts has been to do a prevent suicide program, and the program's actually branded as Prevent Suicide Today. The foundation of that program, something called ASSIST, Applied Suicide Intervention Skills Training. I don't know if anybody here familiar with ASSIST? Several people, excellent. That's an international evidence-based program in St. Louis in a behavioral health setting. We cut our suicide rate among people with serious mental illness from 110 per 100,000 per year to 55 per 100,000 per year, and then sustained it just by training our behavioral health staff in that 2-day role play. It's not a classroom teaching you signs and symptoms. It's really how do you talk to desperate people. So in Savannah, that was something that the county commission funded $40,000 so we could bring the trainers in from Saskatchewan, and we trained 15 people, sheriff's department, both hospitals, school, Gateway, various other community members. Over the years, we've trained 27 different trainers. And that training then is something that people take and use immediately to talk to desperate people. And once a person who does not need to be a healthcare professional, much less a behavioral healthcare professional, once they know how to talk to people that are desperate, you're able to actually hear people that are desperate, and you're not afraid to talk to them. So ASSIST is something we've certainly advocated that all medical schools should make that 2-day workshop series part of the requirement for medical students, regardless of specialty. We've also, there are a number of nursing schools have now put that in their nursing schools, not for the psych nurse track, but for all their nurses, so that all of us are more open to understanding the person in front of us and how to talk to them. The collaboration then in Savannah and Chatham County was that 40,000, but all the agencies and organizations that provided people to become trainers, they did that on their own time, just like Wake has. And then when those trainers, we put on, ASSIST is about 20 people per workshop for those 2 days. And you have to have 2 trainers. So then over the years since 2017, those organizations are supplying their trainers at no charge. And the cost for people to participate is $200 because that's what the materials and the food costs for those 2 days. So very much that has expanded so that Suicide Talks has now been provided for about 14,000 people. We've trained about 12,000 people on how to talk to desperate people. 1,200 people on how to talk to desperate people, but about 14,000 in Suicide Talks, including 100% of the school system employees, bus drivers, custodial staff, cafeteria staff, as well as teachers and career counselors. And basically the message of that training is it's safe to ask about suicide. You're not going to persuade or give somebody the idea of suicide if you ask them if they're feeling desperate or suicidal. And then as that program developed, really just with the one staff member as a director from this planning council, Resilient Georgia provided some grant funding to help that. Healthcare Georgia Foundation did as well. The county continued to annually, and they added to it mindful self-compassion, trauma-sensitive yoga, trauma drama. Trauma drama is a wonderful thing for teenagers and adults that have experienced trauma. And so really looking at how do you get upstream and expand the mental health awareness within the whole neighborhood, if you will. And all those people that never darken the door of a mental health professional and yet do live with desperation and honestly often do successfully commit suicide. You've got a way to get at many more of those people. One last person I want to tell you about is one of our community members on one of our collaborative groups who did not have a high school education. And when she heard about ASSIST training, that we're going to roll that out, she came to me after me and said, Dr. Johnson, that sounds like something I need. And I said, okay. And she said, yeah, I'm kind of the grandmother of my neighborhood. I sit on my front porch and people come and talk to me. I hear all kinds of things, Dr. Johnson. Can I do that? So I said, of course, yeah, you can do it because it is designed for people that listen. So it's good for mental health professionals to take it. It's good for healthcare professionals, but it's for people that listen. So thinking about the whole picture here of a very complex social need we have, I would submit that that has not been an expensive lift to have that kind of impact in the community.
Hey, Mark, talk about, use your words that we talked about earlier on how we need to transition.
Thank you very much. That's a great question, Rick.
He's got a really profound thing to say.
So destigmatization is a word that maintains stigma. Think about that for a minute. You know, we really need to move from destigmatization of mental illness to demystification. Demystification is what programs like Mental Health First Aid, ASSIST do. You know, I remember being an intern. I was scared to ask my outpatients if they were suicidal, and I was training in psychiatry because I was afraid back then that I might give them an idea. So demystification, where we are comfortable talking to each other, actually takes away one of the biggest barriers toward people being willing to engage in conversations about mental illness. And I'll give you just a thought experiment for a minute. How did we move from where we were in the 50s and 60s when it comes to LGBTQX community members to where we are today? Do you recall a big destigmatization campaign? No, that's not how we did it. We did it by exposure to each other. We did it by demystifying. It was, here's who we are, here's where we are. That's what we need in mental illness. That's certainly starting to happen with social media as people under 30 are sharing pretty freely about their experience, but we do need some of these other things to really get to demystify and make it so even though I'm going into OBGYN and I would have gone to psychiatry if I'd wanted to, because they made me take this ASSIST course back in med school, you know, I'm going to have 2 of my staff take ASSIST for my private practice office because I know we get people, I can't talk to them, but we do get people that are depressed after they've delivered, and that kind of thing you were looking for?
It is exactly it. Yeah, it's the education that brings us out into the light and out from behind the curtain, and you know that's just so important so that we all know how to play in this space and how to help.
Yeah, my son who's been suicidal and psychotic, and after his first wife, and he divorced, we sat Shiva with him, one of his buddies and I did, till he kind of recovered over 6 months. But when we thought he was doing okay, he actually gone to London where he'd had lots of good memories. And we got this call from him where he was saying, I'm calling to say goodbye. So my response to him was, you can't do that to your mother and I. So he sat with that. I called the front desk immediately. said, "You've got somebody up in room 317 who's just called me. He's suicidal." You know what they said? They said, "I'm sorry, sir, that's a private, personal thing. We can't really do anything about that. This is a hotel." And I said, no, you're London, England. You've got people minutes away who are trained and equipped to go talk with them. I think you really need to do that. And fortunately, they did. Now, I don't tell the story for that reason, though that's real. I tell the story because when he first started posting, he's a cafe owner and a coffee connoisseur. When he first started posting publicly his experience with being in the hospital and being psychotic, here I was, psychiatrist, dad, kind of taken aback, going public with all that. And then, of course, very proud of him. And we got to be able to be that public. You know, I grew up, I can go on and on, I'll pause in just a minute. I grew up where people talked freely in Kentucky about their heart conditions and their GI conditions and their stomach conditions. Well, we got to be able to talk like that about our psychosis and our depression and our anxieties and our panic attacks and how we help each other and how we recover and how great the wake system was and how great the responders were in DeKalb County. That's where we got to get to pretty quickly, I think.
I want to say thank you to Mark for sharing that very personal story. It's quite enlightening and it shows how prevalent this is. It affects us all personally, even those who live and breathe this day in, day out. You know, in our remaining time, which we don't have much of, I just would like to get, if you had to think about quick hits, you've all talked about different things you've done in your communities, some of them small, some of them big, and I've been really impressed by some of the small things that probably have seismic impact. What are the other ones you could do if you had free reign, which you think we could all learn from and some could even think about executing in the respective markets? So just start with Fabio.
Well, I think going from what Dr. Johnson said, it's making sure that mental health is part of the everyday conversation. So how do we invest in the time with that? Because the more people that can talk about mental health, the more people can recognize mental health. And the more that we're talking about it, the more there's interest in it, the more that there's funding in it. And it becomes not this thing that's put aside or somewhere where you go or only special people can that are trained that can support that. It becomes more part of overall healthcare. You know, we talk about healthcare, a lot of times the first thing that people think about is your surgeries and your heart conditions and strokes. They don't think about mental illness. And so I think we have to get to a point when we talk about healthcare, we're talking about everything that has to do with healthcare. And that is looking at investing ways that we keep that conversation going. So mental illness is seen, and substance use, is seen as being part of that collective discussion about healthcare.
You want to go?
Sure. I would do several things. Mental Health First Aid, which is a program developed by the National Council for Mental Wellbeing. That's the nationalcouncil.org. You'll find it. Has Mental Health First Aid. They've got versions for adults, youth, teen, older adults, public safety, at work, public safety again, it's a typo, fire/EMS, rural, and veterans. On Monday, I got to talk at the American Public Power Association conference down in Savannah. And I was on a panel where we're talking about for public power organization employees, what do we need to do for mental health? Mental Health First Aid is one of those things. I would put it, like I said, in every college and university as a basic fundamental requirement. Second thing, I'd put ASSIST, and we could do this probably nationally for under $2 million with some people volunteering time. Put ASSIST as a required training. It's 2 days, 16 hours for every medical student, every nursing student in America. That would be a transformative experience in healthcare. Then the other thing I'd do is transform the discussion of parity. And I appreciate you mentioned strokes NMI. There will not be, I mean, we got federal laws on parity. Georgia passed a parity law this past year. There will not be actual parity until payers provide the kind of ancillary auxiliary treatment for mental health, for schizophrenia, for major depression, etc., that are currently provided for stroke recovery, diabetes care, home health, and post-cardiac. We don't have that. We've got payment for medications, we got payment for an office appointment. Mental illness, some people taking a pill is enough if they remember to take it, but that's really not what it takes to have a lifelong recovery. We now know that every episode of psychosis produces brain damage. That's what our technology has now enabled us to know for a fact. I hope it will be, and it should be, unethical within 10 years, unethical to allow anybody in America to have more than that first or maybe that second episode. Nobody should be having 4 episodes of psychosis a year. Nobody should be having 10 in their life. The cost, the human cost is devastating. Lack of actual parity is part of that. How would, if you were a payer, for instance, or even a state payer, how would you like to be part of a class action lawsuit in 10 years because you didn't step up and do what it takes to prevent those repeated episodes of psychosis that are producing brain damage? That's a low-cost lift to a certain extent, but it's a very big win financially for employment, social breakdown, people, all the family members wrapped around all those individuals and how it affects them to have family having problems. The economic benefit of limiting people to 1 or 2 psychotic episodes would be incredible. It takes some investment up front to get there, but the long-term 10, 20-year benefit would be absolutely incredible.
Yeah, very good ideas, Mark. I'm going to take this in two different ways. I think there's a lot of answers in behavioral health, but just in healthcare in general, in technology. I think that we are just beginning to really harness that way forward. I think there's a lot more work that has to be done, principally in connecting our EMRs like for real instead of the way they are now. But there's a lot of answers in the data, and there's a lot of answers in tech in the behavioral health space. I get to sit on a couple of boards of some startup companies that are going to make just incredible differences. And they're upstream differences. So it's early detection or actually prediction of disease. So if we know you're susceptible to something, you hopefully never get to see these guys because they're at the top of the food chain from a severity of illness perspective. We can take care of you a lot earlier. And then the second part of my answer is, Sri doesn't know me that well, but I don't follow the rules. Ask my mom, she'll tell you. I ask for forgiveness instead of permission. And it kind of ties to my earlier comments when we first started. I think in this particular space, it's time for major disruption. You can't stick your fingers in the dike and make it work with the kind of volumes we're talking about and how deeply and difficultly our communities are struggling. You can't fix it bits and pieces. If you look at any organization, I say this to our team at WakeMed, they don't like it, but I say lots of things they don't like. It's part of my job. You can figure out an organization's priorities really pretty easily. Any idea how you do that? It's simple. Where do they spend their money? Our government, our payers, our employers. We got to change the game. We got to spend our money differently. I think we're done.
We are sadly out of time, but as you can see, our 3 experts here could talk about this for a lot longer. If you want to have other topics you want to reach, come find them after the panel's over. But thanks everyone for your time, and hopefully next year we'll be talking about some of the big seismic changes in mental health delivery based on what these 3 folks have shared with us today.